I'm pleased to welcome both Jeanne, Tsai, and Tamara Sims today. Jeanne Tsai is an associate professor of psychology at Stanford University and the director of the Culture and Emotion Lab there. Tamara Sims is a doctoral student and a member of the Culture and Emotion Lab as well. Both Jeanne and Tamara have collaborated on some really fascinating work examining how people's beliefs about ideal affect can shape some very important health-related decisions. So I think their work will have a lot to say about how aspects of emotion, beliefs, as well as possible cultural differences in ideal affect can have an influence on the important health decisions that people make on a day-to-day basis. So without any further ado, I'd like to welcome both Jeanne Tsai and Tamara Sims to talk about their work. So take it away.
Great. Thank you, John, for organizing this and for inviting us to present our research to you today. And thanks to those of you who are tuning in. We're really excited about getting your feedback on this work. So as John said, we're going to be talking about ideal affect and its implications for health-related decision-making. And what I'm going to do is provide the context for this work and specifically say what we mean by ideal affect. And then Tamara is going to take the majority of the time and talk about the links between ideal affect and the kinds of decisions that we make in health context. Particularly, she's going to be talking about physician choice. Okay. So most people want to feel good, but our research suggests that people really differ in the types of good states that they want to feel. So for example, in one study, we've asked participants to tell us what their ideal state is. And here are some examples of what they say. So I think a little bit of a lag. Okay. So a prototypical European American college student response is, I just want to be happy. Normally for me, that would mean doing something exciting. I just want to be entertained. I just like excitement. In contrast, a typical Hong Kong college student's response is, my ideal state is to be quiet, serene, happy, and positive. And so what I want you to notice is that both responses talk about feeling happy and feeling good, but for the first response, feeling happy or feeling good means being excited, feeling a lot of excitement, whereas the second response really focuses on being quiet, serene, feeling calm. So for that person, happiness really means feeling calm. And so this is really what we mean by ideal affect. By ideal affect, we mean the, we mean affective states that people value, desire, and ideally want to feel. And many of you may know what we mean by affect, but in case you don't, we're using the term affect to really describe different feelings that can be described in terms of two dimensions, the dimension of valence, going from pleasant to unpleasant, and the dimension of arousal, from high to low arousal. So this means that different feelings may be equally positive, but some of them may be high arousal versus low arousal. For example, excited is as positive as calm, but excited involves a high arousal state, whereas calm involves a low arousal state. So we focus on affective states because we know from a number of cross-cultural and cross-linguistic studies that across a variety of different cultures, and particularly the cultures that we've been interested in, people categorize their emotions using at least these two dimensions of valence and arousal. And so we wanted to use these states because we wanted to ensure that they had similar meaning across cultures. Now, most of the research in psychology has focused on what we call actual affect, or the affective states that people actually feel. So actual affect is like a response or a pattern of responses to a number of different events. But much less research is focused on what we call ideal affect, or the affective states that people ideally want to feel. And we think this distinction is really important for a whole host of reasons. And we conceptually think that they're very different. And so to test this idea, we've just given a number of different samples, college students, community samples of adults that range from middle age to older age. Our measure of ideal and actual affect that's based on existing measures of what we call actual affect. So in this measure, we just ask people how much they actually feel a number of different states, specifically the states that I showed you in the earlier figure on the affective circumflex, how much they feel these states over the course of a typical week or on average or in a given moment. And then we also ask them how much they ideally would like to feel those same states. And we give them a rating scale from 1 to 5. And what we find is that across the different samples that we've administered this measure to, people report wanting to feel more positive than negative, and they report wanting to feel more positive than they actually feel, and wanting to feel less negative than they actually feel. So this provides some empirical support for the idea that ideal and actual affect are different things. There may be particular situations where we're feeling exactly how we want to feel, but overall we don't feel how we want to feel. When we use more sophisticated analyses like structural equation modeling, we also find that these are really distinct constructs. And we think that it's important to differentiate between actual and ideal affect, like I said, for a variety of reasons. The work that inspired our interest in ideal affect really started from this question of how does culture influence how we feel. So for a whole host of reasons that I don't have time to get into, we predicted that based on earlier work and other work by other investigators, that although culture influences how we actually feel and how we ideally want to feel, culture influences how we want to feel even more than how we actually feel. And so in the same samples that I talked about earlier, where we found a distinction between actual and ideal affect, we've also found support for this hypothesis that culture influences how we want to feel more than how we actually feel. For example, in this graph I have here just on the x-axis the excitement states and the calm states, and on the y-axis their ratings. They're ipsitized or standardized within individual to control for any cultural differences in response styles that other people have demonstrated. And what we find is that European Americans here in red report that they want to feel the excited states more than the Hong Kong Chinese here in blue. And the Hong Kong Chinese in blue want to feel the calm states, the low arousal positive states, more than the European Americans in red. The Chinese Americans here, who are bicultural or oriented to both American and Chinese culture, are like their European American counterparts in that they really value the excitement states more than their Hong Kong Chinese counterparts. But they also value the calm states, like their Hong Kong Chinese counterparts, more than their European American counterparts. These differences have emerged across a variety of different samples. And what's interesting is that sometimes we find cultural differences in actual affect, or how much they actually feel these states, but more often than not we find no differences in how much people actually feel these states. When we control for these differences, we always find cultural differences in ideal affect. So the absolute level may sometimes change, but the cultural difference illustrated here and here always persists. And in addition to finding these cultural differences, we always find individual differences within a culture, and I'll talk about those more in a second, and that's what Tamara is really going to focus more on. Okay, so in addition to seeing these differences in people's self-reports of emotion, or actual affect and ideal affect, we've been interested in how these differences are reflected and reinforced by cultural products. So we've done a number of studies where we've looked at the content of different cultural products and to see whether or not they reflect these differences in ideal affect. And what we find, for example, is that in best-selling storybooks in the United States and in Taiwan, after we've coded the emotional content or the types of smiles that the characters show, we find that the American storybooks have more excited expressions and fewer calm expressions compared to the Taiwanese best-selling storybooks. So you can see this excited smile here and this calm smile here. We also have looked at American and Chinese women's magazines, and again we find that the American women's magazines have more of these excited smiles and fewer of these calm smiles compared to the Chinese women's magazines. And so the idea is that people get exposed to these different affective states, and they learn to endorse them and value them, even unconsciously. People, I don't think, are really aware until we ask them how they want to feel or what their affective preferences are, but they have them and they're reinforced by the culture. So we think this is important for a variety of reasons, and for the purposes of today, I'm just going to talk about the implications that ideal affect has on one aspect of our daily lives, like what we do to feel good. So we've done a number of studies that have looked at people's recreational activities and even their consumer product preferences, and we find that ideal affect, even more, so how people want to feel, even more than how they actually feel, influences what activities they choose to engage in and what kinds of products they choose to consume. So for example, in one study, we presented European American, Chinese American, and Hong Kong Chinese participants with the choices of different types of consumer products. For example, they were given the choice between a calm or a soothing or revitalizing gum, calming or lively lotions, an exciting CD versus a calm CD, or even different waters that were either relaxing or energizing. And what we found was that European Americans were more likely to choose the exciting consumer products than their Chinese counterparts, and that these cultural differences were mediated by how much they valued excited and calm states. So again, at both the cultural level and at the individual level, it seems like how people want to feel, even more than how they actually feel, is influencing what kinds of things they're choosing to engage in. So when Tamara joined my lab a few years ago, she was interested in the role that ideal affect plays in health contexts. And so it might not be surprising that how you want to feel influences different recreational choices. But her question was really, would ideal affect influence more consequential decisions, in some ways more serious decisions, like what kind of physician you would choose? And so what she's going to do is talk about her work, a series of studies looking at this. And she's going to focus first on the individual level, and then when she talks about some of her current projects, she'll talk about this at the cultural level. So here's Tamara.
Okay. Thank you, Jeannie. Oh. Sure. Okay. Hi. Okay, so I want to start off by asking all of you to imagine that your current position is no longer available and you have to choose among two new positions. There we go. One more. Okay, so I want you to think about what factors are most important in determining your choice. We did a quick survey on Amazon MTurk, and we found that the three most important factors were affordability or cost, the location of the physician, and their credentials. But you can imagine, especially in the United States, most people with jobs have managed health care plans where things like cost and location are relatively similar across the physicians that they're choosing from. There have been surveys of employees with managed health care plans, and among these participants, while education and credentials are still among the top-ranked factors that go into how people decide among physicians, the number 3 ranked factor was patient satisfaction with the physician's interpersonal skills. And what exactly is meant by interpersonal skills, it was a little unclear in this study, but one important component of it might be the emotional connection that's established between a patient and their physician. And there's a large literature showing that emotion or affect is a critical component of a successful patient-physician relationship. So in particular, the more emotion or more affect that a healthcare provider expresses, the more positive the patient outcome. So patients that engage with healthcare providers that are more expressive are more satisfied. They're less likely to sue their surgeon, and they even have better health outcomes. So older adults that were in a rehab facility, when we're engaging with a physical therapist who smiled more, did better both at discharge and even 6 months later at follow-up. So while this establishes that emotion is key, central to patient-physician relationships, there are some limitations. For example, one thing we don't know is whether the effective expression of the physician and sort of the positive outcomes associated with that might depend on how much the patient values emotion, expression of emotion during their encounters. So one limitation is that very few of these studies, with a few notable exceptions here, consider the emotional goals of the patient. Another limitation of this literature is that while, like the affective decision-making literature more generally, negative affect is pretty widely differentiated. So people look at expressions of concern, anxiety, even hostility. Very few studies differentiate positive affect. So usually they just sort of look at positive expression more generally, and they don't distinguish among different types of positive states, such as excitement states and calm states. So the goal of our research is really to examine whether these sort of benefits to patient outcomes in terms of physician affect depended on the type of positive affect expressed by the physician, but also depended on the match to patients' emotional goals or their ideal affect. So like the recreational choices and the consumer product choices that Jeannie was describing, we would predict that ideal affect would shape our preference for a physician above and beyond actual affect. So for example, you can imagine a physician who promotes energizing his patients might be more appealing to a patient who really values feeling energetic, presumably because this physician is going to prescribe treatments and engage with the patient in a way that helps them reach their ideal state. So in this case, we're really talking about physician choice depending on a match with the patient's goals. Now, an alternative hypothesis would be this sort of general match or general feeling of similarity to the physician. So in this case, you could imagine that how the patient actually feels would be as important in determining physician choice as how the patient ideally wants to feel. Now, a third possibility is that a match in temperament or actual affect might be even more of an important predictor of physician choice than ideal affect. So, so in this case, we'd see that actual affect would predict physician choice more so than ideal affect. So the nice thing about looking at ideal and actual affect simultaneously is we can see if this association between ideal affect and physician choice is a result of simply matching in general. So I want to feel energetic. I tend to feel energetic. This doctor promotes feeling energetic, so I like him. Or whether this is specifically about this physician's going to help me to meet my goals, which is what we're predicting. And it's important to note that we don't think people are necessarily aware of this process. So ideal affect can shape sort of our physician choice at a more automatic, non-conscious level. So it sort of shapes our gut feeling or our general impression about the physician. And the patient might not necessarily be aware that that's the factor that's going into their preference. So today I'm going to show you a series of studies where we examined this research question. And first we looked at the association or the influence of ideal affect on choice of physician. And in the last study, we'll talk about whether ideal affect predicts also how people respond to a physician that promotes different types of affective states. So in the first studies, we just wanted to start off by establishing whether there was even a relationship between ideal affect and physician choice. And we did this by surveying both a college student sample and a community sample. And we gave them the AVI, the Affect Valuation Index, to assess both their ideal affect and their actual affect, as Jeannie was describing earlier. And then we also gave them a hypothetical scenario in which we asked them to imagine that they had to choose among two physicians, much like what I presented to you when we first started. And these physicians, so they saw two physicians that were matched in terms of education, in terms of experience. The only thing that differed between these physicians was the positive affective state that they were promoting. So one of the physicians was Dr. H, and Dr. H's views on patient care was enhance patient well-being by increasing their activity levels and overall vitality, so patients could lead dynamic lifestyles. And its hobbies were more exciting hobbies like rock climbing, water skiing, snowboarding, and football. And then participants also saw Dr. L, whose views on patient care were to ensure that his patients had peace of mind when it came to their health by promoting a stress-free lifestyle. And his hobbies included golfing, meditation, gardening, and fishing. So then we asked participants to choose which physician they would prefer to provide their regular care. So when looking at whether ideal affect predicted physician choice, we regressed actual affect and ideal affect onto their choice of the Dr. H, or the HAP physician, over Dr. L, the LAP physician. So on the y-axis here, you can see the probability of participants choosing the HAP physician, and on the x-axis is either their ideal or actual affect. So the dotted lines represent actual affect and the solid lines ideal. And we found no relationship between actual affect and physician choice. However, we found a significant effect of ideal HAP. So the more people valued high arousal positive states, the more likely they were to choose Dr. H, the HAP physician, over Dr. L, the LAP physician. Now, unexpectedly, we found no relationship with how much people value low arousal positive states. And we thought this might be because this was a young college student sample, and as you saw earlier, high arousal positive states might tend to be endorsed more by young American college students relative to other cultures. So we thought we would recruit a more diverse community sample that ranged across the lifespan, because we know there are age differences in ideal affect as well, and consisted of two cultural groups, Chinese American and European Americans, to see whether how much people value low arousal positive states might be more salient among a more diverse sample. And here we actually found the same pattern of results as the college student sample. So we found no relationship between actual affect and physician choice, but how much people valued high arousal positive states did predict choosing Dr. H over Dr. L, where again, how much people valued low arousal positive states did not predict. So another possibility, so while we found some support for our hypothesis that ideal affect predicted physician choice above and beyond actual affect, we wanted to see, well, there were two issues with this study. One was, these were correlational studies. So we wanted to next conduct an experiment to see whether if we manipulated ideal affect, we would then see that it would affect physician choice. But also we thought, because this is, even with Chinese Americans and European Americans, this is a primarily American sample, that how much people value low arousal positive states in an American context still might not be a salient when predicting choice. So a second reason for our experimental study was to enhance the salience of how much people value low arousal positive states, to see if that would then influence their choice of physician. So to do this, we experimentally manipulated ideal affect by adapting a values affirmation paradigm, in which we had people sort of write about a personal experience touting the benefits of either high arousal positive or low arousal positive states. And I'll walk you through what we did. So a third of the participants were randomly assigned to the value HAP condition. In this condition, they read this paragraph where they were told that researchers discovered the secret to happy and fulfilling life is feeling stimulated and invigorated, and that this had consequences for all sorts of life outcomes like life satisfaction and relationships. Then participants were asked to write this one paragraph supporting this statement based on their own personal experience. Another third of participants were randomly assigned to the value LAP condition, where they were to write about the benefits of feeling tranquil and well rested. And a third of the participants were assigned to a control condition, where they were to write about an experience that had nothing to do with emotion per se, but just the secret to a happy and fulfilling life is having an objective outlook and sense of purpose. And then they saw a similar hypothetical physician scenario as in the previous studies, where they read descriptions and chose between Dr. H or Dr. L. And when looking at the percent of people choosing the HAP physician, we found a significant effect of condition. So that participants in the value HAP condition were most likely to choose the HAP over the LAP physician compared to the other two conditions. And then what we decided also to look within condition to see whether or not within each condition, the choice of physician significantly differed from chance. So you can see here at the 50 line, this is our choice of physician by chance. And we found that within the value HAP condition, participants were significantly more likely than chance to choose Dr. H, a HAP physician, over Dr. L. Whereas people in the control condition did not significantly differ from chance. And while people in the value LAP condition were less likely to choose the HAP over the LAP physician, these did not significantly differ from chance either, suggesting that even when we increase the salience of ideal LAP, we don't see a significant effect on their choice of physician. So again, we were able to find that the more people, that ideal HAP seems to influence physician choice, whereas in this case, ideal LAP did not. So at this point, we were pretty puzzled as to why ideal LAP wasn't predicting physician choice when it had in some previous, with other types of products. And it occurred to us that one of the reasons might be that in all these studies, the LAP physician was presented in direct contrast to the HAP physician. And it might be that when you're sort of perceiving the physicians, that rather than the LAP physician being perceived as promoting some sort of positive emotion, he's perceived rather as being neutral or non-emotional. So it's not that it's HAP versus LAP, but more that it's HAP versus not HAP. So we decided that we would add a non-emotional or a neutral physician to really bring out the affective qualities of the LAP physician. So we added Dr. N as a third choice, and his views on patient care were to administer medical care to his patients by providing information and making recommendations in order to help them maintain a healthy lifestyle. And we assessed physician choice because we had three choices. Instead, we used a continuous rating of how likely participants would be to select each of the physicians, Dr. H, Dr. L, and Dr. N, just on a 7-point scale. And for Dr. N, as expected, we found no effects of of ideal affect or actual affect on how likely they would be to select the non-emotional physician. And when looking at the HAP physician, we found a similar pattern of results as we found for the choice studies earlier. So the more people valued high arousal positive states, the more likely they were to select the HAP physician, where ideal LAP did not predict their likelihood of selecting the HAP physician, nor did actual affect. When we looked at the LAP physician now being rated in the context of comparing them to the HAP physician and the neutral physician, here we found ideal LAP does predict choice of the physician. So the more people value low arousal positive states, the more likely they were to select the LAP physician, whereas actual affect did not predict. And in this case, how much people valued high arousal positive states did not predict their preference for the LAP physician. So these studies support, first off, that ideal affect seems to predict physician choice more than actual affect. And importantly, when including a neutral option, ideal LAP now predicts preference for the LAP physician, suggesting that possibly when directly comparing the LAP physician to the HAP physician alone in American context, that the LAP physician might be viewed as neutral or non-emotional. So the next step, we really wanted to see all these studies up to this point were really looking at hypothetical choices. And we wanted to see whether, okay, if you actually assign a patient to engage with one of these physicians, would ideal affect matter when they're deciding whether or not to adhere to the physician recommendations? And so to do this, we recruited a community sample from the San Francisco Bay Area across the lifespan. They're a culturally diverse sample. And we recruited them to participate in a virtual health center pilot study. So the cover story we had was we told participants that we're starting up this virtual health center, and we want to get your feedback on the website and on our virtual physician. So we would like you to sort of engage with the website and the physician and give us your feedback. So we screened participants for any significant health problems, one, just for their own safety, and then two, to ensure that they would be able to follow the recommendations should they choose to do so. And then if they passed the screening, we had them call in over the phone for the first sort of initial intake session. And at this time, we had them review the Virtual Health Center website. They filled out a health assessment, and then they were assigned to their virtual physician. So I'll walk you through this part now. So this was the homepage of the Virtual Bay Health Center, and this was sort of the mission statement. After they read that, they clicked here to take a health assessment, where they just provided some information on their general physical and mental well-being. And then we brought them to their Meet the Virtual Physician page. Now, half of the participants we assigned to the lap physician, who is shown here, and the other half of participants were assigned to the HAP physician. And it's important to note, so in this particular study, participants only saw the lap physician, so they didn't see the lap physician in contrast to the HAP physician. And then they were able to look over the web page. They watched an introductory video, and at the bottom here you'll see there's a description of the physician, much like what we had in the hypothetical healthcare scenarios. And so I'll go ahead and play the introductory video that participants saw when engaging with the lap physician.
Hi, I'm Dr. Stephen Jones. I'm pleased to be assigned as your personal virtual physician. As your physician, my goal is to ensure your well-being by promoting peace of mind when it comes to your health, so you can live a more...
Okay, so I'll just go ahead and go to the next one. Hopefully you got an idea of the calm physician, and now you can see the excited physician.
Hi, I'm Dr. Jason Smith. I'm excited to be assigned as your personal virtual physician.
And there wasn't a lag on the actual website.
My goal is to enhance your well-being by increasing your activity levels and overall vitality, so you can lead a more dynamic, energetic lifestyle. I believe that the key to a long, healthy life is to have an enthusiastic attitude and approach each day with passion and zest. Finding exhilaration will lead to good health. Engagement in vigorous, strengthening activities while keeping in high spirits can help you get fit and feeling great. Today, we will begin by giving you a general health assessment. And once I review the results, I'll provide you with a health program to follow for the week. Then we can meet again to review how your week went and determine whether we are meeting your health goal.
Okay, so after they viewed the physician video, we told participants the physician was going to review their health assessment and then get back to them. They would call back in a couple days to get their personalized feedback. And so we had them, when they called back in a couple days later, there we go. They called back in a couple days later, we had them log into their website using a login ID and a password to sort of keep up the guides that this was personalized, when in fact everything we gave them was standardized across participants. This was a feedback page they logged into. They watched another video just with either the calm physician being his calm self or the excited physician being his excited self, in which they encouraged them to follow the recommendations for the week. They received feedback on their health assessment. You can see here everybody was told that their health was good, and this was so that they had some room for improvement, so they would be motivated to engage in the health recommendation or follow the health recommendations, but not too poor so that they'd be discouraged from actually following them. And then if they could then scroll down the same web page, and I'm just zooming in here for illustration purposes, and they were shown the recommendations provided by the physician. And so there were 6 recommendations they were given. One was 10 minutes of muscle strengthening activities, another 30-minute brisk walk, 15 to 20 minutes of napping or resting, no more than 1 caffeinated beverage a day, drinking at least 1 glass of water, and abstaining from eating at least 2 hours before bedtime. They were asked to start following these recommendations the following day after they received the feedback. And then the morning after the first day that they followed the recommendations, they were asked to report both how they, their ideal and their actual affect, as well as whether or not they adhered to each of the recommendations on the previous day. So then every morning after, they would report on the previous day's behavior in terms of their adherence and their ideal and actual affect. So they completed these daily logs for 5 days. So days 4 to 8, they would do the daily logs. And we calculated daily adherence for these 5 days. So within each day, we totaled up the number of recommendations they followed. So if they didn't follow any recommendation, if they didn't follow the recommendation at all, they received a score of a 0. If they attempted to follow it, we weighted that, so we gave it a score of a 1. So a lot of people would report that they did 20 minutes of walking instead of the recommended 30 minutes. So we gave them a score of a 1, and then people that fully adhered to it, did the full 30 minutes of walking, we gave them a score of a 2. And so for each day, we added up the total number of recommendations so that there was this kind of scale, as you can see here on the y-axis, ranging from 0 to 12 within each day. And then we averaged across the 5 days. And here is just kind of on average the difference in adherence between the HAP physician participants and the LAP physician participants. And we actually found no significant difference between the physicians in adherence behavior. And the nice thing about this design was it allowed us to use multi-level modeling to examine our data. So we could actually look within participants predicting their adherence. So we could look within participants at both ideal and actual affect, predicting adherence behavior for each participant across the 5 days. And then at level 2, we could assess the affective condition. So was there a significant difference on the association between ideal affect and adherence between the HAP physician and the LAP physician? So here on the y-axis, we have the association as represented by an unstandardized beta coefficient, the association between affect and adherence. And on the x-axis, we show the effects of ideal HAP, ideal LAP, actual HAP, and actual LAP. So we want to see whether there's a significant difference between the physicians on the effect of ideal HAP. And we did find that the HAP physician differed from the LAP physician. So for the HAP physician, the more people valued high arousal positive states, the more likely they were to adhere to the HAP physician. However, how much they valued high arousal positive states did not significantly predict adherence to the LAP physician. And for ideal LAP, we found the reverse pattern. So we found a significant difference between the two physicians. So for the LAP physician, the more people valued low arousal positive states, the more likely they were to adhere to the LAP physician, whereas ideal LAP did not predict adherence to the HAP physician. And importantly, we found no significant difference between the physicians in the effect of actual affect on adherence. So again, this seems to support our hypothesis that ideal affect predicts response of physician above and beyond actual affect. So just to summarize these 5 studies, we found that in the first 4 studies, choice of a physician either promoting HAP states or LAP states is really shaped by a match in ideal affect, but not an actual affect. So it really seems to be about meeting the patient's goals as opposed to just a sort of perceived similarity to the physician. And we found a similar pattern for adherence to recommendations by a physician promoting HAP or LAP states. And importantly, in studies 4 and 5, we showed that when the LAP physician is not in direct contrast to the HAP physician, ideal LAP also emerges as a significant predictor, much like ideal HAP, in how people respond to a physician. So currently, we're really interested in looking at the mechanism that's underlying the relationship between ideal affect and physician preference. We predict that the choice of physician really depends on how ideal affect shapes how we perceive the physician. We're specifically interested in this perceptions of trustworthiness of the physician because trust has been linked to sort of patients deciding to continue care with their physicians, and trust predicts is linked to patient satisfaction with physicians. So what we were predicting was that ideal affect really shapes how positively people perceive the physician in terms of trustworthiness, and that would then predict physician choice. And in a number of studies, we're finding support for this hypothesis that it's perceived trustworthiness of the HAP physician, for example, explains the effective ideal HAP on choosing the HAP physician. Another direction that we're currently going in right now is looking at, so as Jeannie described at the very beginning, there's substantial cultural variation in the emotions that people ideally want to feel. And we want to see whether those cultural differences translate to cultural differences in choice of and response to these physicians. So we have several studies testing this hypothesis. One that's sort of hot off the presses is where we show participants health message videos, either given by a HAP physician or a LAP physician. And we're looking at both European American and Asian American college students, and we match them by ethnicity. So half the participants, the European Americans, see this HAP physician here in the top left. The Asian Americans see this HAP physician on the bottom left. And then participants, the other half see the LAP physician, and the physician gives them 9 recommendations throughout the course of the video. And at the end of the study, we ask participants to recall the recommendations that the physician provides. And we are finding that European American college students recall more recommendations when provided by the HAP physician compared to Asian American college students, and this is relative to the recommendations recalled by the LAP physician. And then all of these studies, we're sort of talking about patients' perceptions of physicians, but we're also interested in the flip side. So clinicians are people too, and we would expect that clinicians' ideal affect might shape their perceptions of their patients as well. So we want to know whether how this plays a role in sort of evaluation and treatment of patients in both clinical, in medical settings and therapeutic settings, mental health settings. And so these findings have implications for a variety of domains, including patient-physician communication. So you might, so we know based on these findings that affect is important in the patient-physician relationship, but that ideal affect may be as, if not more important in determining how people respond to their physician. So you can imagine the appeal of a physician might really depend on whether the emotions they express match how the patient wants to feel. So doctors, or even these health marketing campaigns like this one from Kaiser that are promoting excitement and enthusiasm might be appealing for people that value these states, but might not be so much for people that don't. This work also has implications for health message framing, where we know, thanks to John Updegraff and his colleague Kristen Gallagher, that the effectiveness of game-frame health messages really depends on a match in goals in terms of motivational tendencies like approach avoidance motivation or regulatory focus. But here we show that effective goals also matter. So the effectiveness of these messages might also depend on differences in the types of emotional goals that people have. So just to conclude, I want to thank all of you for your attention, and John for organizing this virtual brown bag, as well as our co-authors and collaborators, and of course the research assistants and funding agencies without whom this work would not be possible. So thank you very much, and we're happy to take any questions.
Cool. Thank you, Jeannie and Tamara. Again, if anybody has any questions, you can go ahead and just raise your hand with the little hand icon or enter a question into the chat box, and I can reel it on. Actually, I had one question. Am I echoing?
No, we can hear you great.
Okay. Actually, that was not my question. But I was wondering, you mentioned something about part of your match or effect sort of being driven possibly by, like, you know, LAP people perceiving sort of higher goal congruence with a HAP position. In one of the fifth study that you talked about, you mentioned a number of the behaviors that the doctors were recommending seem to be a mix of sort of like energetic behaviors and those that are a little bit more restful. And obviously all of those are sound health recommendations. I'm just wondering if you saw any difference in terms of the kinds of behaviors that the people were engaging to. Say, for example, with the HAP people, you know,
Yeah, that's a great
adhering
question.
with. Yeah.
I'm right now, I'm kind of looking at sort of the individual behaviors. There's obviously the aggregate, you have a little bit more reliability across the week. But it seems like for example, I was looking at the Affective Ideal Lab and the lab physician recommendations. It seems particularly strong for the muscle strengthening exercises, which we would classify as lap. But I'm still kind of analyzing that, so I want to say with a caveat that it's not fully cooked yet. And then one interesting side note is that I noticed also that Asian Americans have an easier time following the caffeine recommendation than European Americans. So it'd be interesting to see whether or not that's also due to differences in how the value placed on HAP states, and that European Americans might value HAP to the extent that they just can't not drink their caffeine every day. But again, those are preliminary.
Which is, it's interesting, it's kind of consistent with some of the literature looking at lithium treatment for bipolar patients. So for American bipolar patients, they're just notorious for not complying with their mood stabilizers, their lithium. Whereas in Hong Kong, there are no problems with bipolar patients taking their lithium treatment or their mood stabilizers. And one reason may be that the mood stabilizer for Americans takes them away from the American ideal of feeling, the high arousal positive states. Whereas for the Hong Kong bipolar patients, the mood stabilizer brings them closer to their cultural ideal.
Cool. Interesting. Sarah Pressman has a question about clarification. She was wondering, how are you typically measuring actual HAP and LAP in your studies? Is it like a current state, momentary, a general mood, trait measures?
Yeah, that's a good question. I should have clarified that earlier. So in the first 4 studies, it's a global measure of actual and ideal affect, so how they want to feel in a typical week. It's not momentary. In the 5th study, we ask, it's a little more like momentary in the sense that we ask how they want to feel and how they actually feel on the previous day. So it's recalled ideal and actual affect, but it is at the daily level as opposed to a more global level. And all of these are on a frequency scale, so not an intensity scale. Okay. Oh, and I'm sorry, the global measure and the daily measure are highly correlated as well, so they're correlated about 0.6 or so.
Okay. Yeah, actually, that was a follow-up question that Sarah had, so you anticipated the rest of the question. Bill Klein has a question as well. First of all, he comments this is very interesting work. He says, I'm sure this is a very pedestrian question, but I wondered if you had thought about whether ideal affect outperforms not only actual affect, but also anticipated affect, like the way it is defined in affective forecasting literatures in predicting health decisions.
Yeah, that's a great question. Jeannie could probably say a little bit more. I would just say that based on this, I think the assumption here is that they are anticipating feeling the state. So it's sort of that anticipated affect. In these cases, is sort of the prerequisite to ideal affect mattering. But I know you've done some work now looking at how those shape each other.
We haven't really pitted anticipated affect against ideal affect in predicting different kinds of choices. But another graduate student, Louise Chim, has been interested in looking at how ideal affect influences how we respond to particular types of events. So for example, if you really value calm a lot, do you enjoy calm activities more? And so in those studies, when she's looking at response to like a calm activity, she measures anticipated calm to the activity, or anticipated, enjoyment, actual enjoyment, online enjoyment, and then recalled enjoyment. And it does seem, at least for valuing calm states, the more you value the calm states, the more likely you are to anticipate enjoyment during a calm activity, the more likely you also are to actually enjoy the activities when you look at online, and the more likely you are to recall enjoying the activity. But it seems like when it comes to valuing excitement, the effect of valuing excitement on these different aspects, anticipated, online, and recalled enjoyment, is less clear. It seems like it has a relatively smaller effect. So those are the contexts in which we've looked at how ideal affect influences anticipated affect, but we haven't really specifically looked at which is a better predictor of somebody's choice. That would be really interesting to do.
Mm-hmm.
All right, great. Well, it doesn't look like there's any more questions, and we're also just about out of time. But I just want to thank you both, Tamara and Jeannie. This is really fascinating stuff, so thanks for taking the time to share it with the group.
Absolutely.
Thank you.
Thanks so much, John, and thanks to all of you guys, the millions of viewers out there.
Yes, exactly, millions.
Millions, yeah.
All right, just to let you know, this is the last virtual Brown Bug that we'll have before we sort of take a hiatus for the summer, but in the fall we'll have a new set going on, so look out for some announcements. And again, thank you, Jeanne and Tamara. And with that, we'll finish up our hour. Thanks, everybody.
Great, thanks. Bye-bye.